everybody. Thank you for joining TB 101 series. I'm going to start a couple of minutes late just to give more people opportunities to join.
There's something extraordinary about Terry.
Okay, everybody. I think it's 10:05 and we have almost 30 people who are joining today. So I think we can go ahead and get started. We have Dr. Freeman who will be speaking with us today. He'll be speaking on monitoring patients on TB treatment. Dr. Freeman is a member of the Division of Infectious Disease and the hospital epidemiologist at Cooper University Hospital in Camden, New Jersey. He has been the senior medical consultant for the Camden County and Southern New Jersey Regional Chest Clinic since 2001. He is a founding member of the State of New Jersey TB Medical Advisory Board, and he has particular interest in management of HIV and TB co-infection. He's also the Associate Professor of Medicine at Cooper Medical School of Rowan University. Thank you, Dr. Freeman. Over to you.
Thank you for the introduction. Hi, folks. I am obviously somebody who does a lot of work with tuberculosis. And what I've been tasked with today is to give you a talk on monitoring people who are on treatment for tuberculosis, who are on anti-tuberculous therapy. So let's get started. There are some poll questions embedded in this talk. And there are also a couple of not really poll questions, but sort of opportunities to sort of fill in some blanks and talk about what you think. All right. So, and obviously any questions you have, there will be people monitoring them and we'll get around to answering all of them. All right, so let's get started here. All right, so let's talk about monitoring of tuberculosis in the past, because it's important to understand where we were to understand where we are now. So let's go into this is actually the non-medical literature. This is actually back in 1899. And this comes from the video game Red Dead Redemption. I actually don't play this game, but my son has, and he's the one who told me about it. And in the video game, the protagonist, Arthur Morgan, gets infected with tuberculosis early on. And this is actually him getting spit in the eye by somebody who was infected, who was sick with tuberculosis. And then throughout the course of the video game, you watch him get sick, get diagnosed, and then ultimately, no matter which path you take, eventually dying of tuberculosis. His treatment, and this was state-of-the-art treatment in 1899, was a bunch of herbs that did help his symptoms some, but really didn't change the outcome of what happened. And monitoring at that time was basically watching to see what happened. So let's fast forward about 25 years from there and go back about 100 years. And this is state-of-the-art monitoring of TB treatment in the United States in the late 20s. This is a scene from Saranac Lake, which is the site of many of the initial US sanatoriums, although some of the largest sanatoriums that came on shortly after this were the large urban sanatoriums built in many of our big cities. You can still see some of the ruins of the TB sanatorium at Seaview at Staten Island, which was one of the largest in the United States. And here they are out on the porch. So what exactly did they do for treatment and monitoring at that time? They treated them with, healthy food, fresh air, and sunshine, and they monitored them by watching to see what would happen. All right, so let's forward 100 years or so after that to this era. And this is an era where you can see this line graph just shows you the evolution of anti-tuberculous therapy and the serial introduction of our older TB drugs, most of which we still use now, as well as the sort of increase in new drugs over the last few years. The good news is that there is a lot less tuberculosis around, especially in the United States compared to 100 years ago. And we have a lot more drugs to treat people. However, our patients are increasingly complicated. We're dealing now with resistance to a lot of our drugs, and there's a lot less expertise in treating tuberculosis. So people aren't as familiar with how we monitor folks. So that's our introduction. So let's start and talk about monitoring. So what happens when you start somebody on anti-tuberculous therapy? Well, that depends on whether you're treating them for TB infection or you're treating them for TB disease. If you're treating them for TB infection, the assumption is that they are basically well to begin with. And you hope that when you start medications, they stay the same. If they do happen to get worse, this could be because we've done something bad with our medications, or much less likely, they might actually have had TB disease that we misdiagnosed as TB infection and then developed symptoms of TB disease. But most of the time, we're hoping we start our anti-tuberculous therapy for TB infection and nothing happens and they stay well. On the other hand, if you treat for TB disease, usually they start with symptoms. So we hope that they get better. And sometimes they stay the same, especially if they weren't that sick to begin with, or they can get worse, or better in some ways and worse than others. And some of that may be due to their TB disease. Some of that may be due to their medications. And trying to sort that out is a little bit of a challenge. So why isn't my patient who's on treatment for TB disease getting any better? Or why maybe are they even getting worse? Some of that may be due to medication-related issues, and we'll come back and talk about that a little bit later at the end of this talk. And there's a number of those. Their drugs might not be being taken, which we hope doesn't happen when people are getting directly observed therapy. Maybe we're not dosing them correctly. Maybe they're not absorbing their drugs as well as we'd like, so their drug levels are low. Maybe they have drug resistance that we're not aware of, or they have drug interactions that make their drugs less effective or may cause toxicity from other drugs, or they may be having drug toxicity from their medications. And we'll talk a lot about that towards the end of this session. Then there are disease-related issues. Sometimes people with really severe disease take a long time to get better. They may develop new complications of disease. Sometimes you'll find that they actually have TB in other places you didn't realize that may manifest even when they're starting on treatment. They can develop increasing inflammation to the TB disease they already have. We most commonly think about this as what happens with people with advanced HIV infection and tuberculosis who develop immune reconstitution syndrome, or IRIS, and all of a sudden have TB lesions that were asymptomatic before, but now their body recognizes them as bad stuff and starts to respond to them. But this can also happen in people who just are really immune depleted, maybe just from bad TB. And as they start to get better, they can do the same thing. And sometimes people actually need surgery, not that often, but they have TB disease that's not going to get better without surgery in some way, shape, or form. So, since we know people can get better but can get worse, what's in our toolkit for seeing how well they're doing? So there are a couple of things we can do. One is our clinical evaluation. We're going to obviously talk to them and examine them and get a history of what's been happening. And then there are some specific clinical components that we think about that we'll talk more about in a minute. We also have microbiology, and this is especially true for pulmonary disease, where we're looking at what happens to their sputums. Are they getting fewer, are they clearing those acid-fast positive smears that they had in the beginning? Are they sterilizing their cultures? And how often do we measure that? We can do additional chest x-rays, and then there are laboratory tests that we do that may be monitoring on treatment, and we'll talk about those in a second. So in general, when we follow patients on anti-tuberculous therapy who are doing okay, we're going to be seeing them generally in most clinics at least monthly, sometimes less frequently if they're later in treatment and doing very well, but at least in the beginning, at least monthly. And sometimes if they're having problems, that has to be more frequently as we try and sort out their issues. We're going to look for treatment of efficacy. We're going to see if their TB symptoms that they started with are getting better. If they presented to the hospital or to your clinic with cough and fever, fatigue, and loss of appetite, good signs that they're doing better are resolution of those symptoms. Their fever's gone away, their cough is improving, they're starting to eat and gain weight. So one of the reasons why that measure of their weight and watching them gain weight is something that we like to see. Then we're also going to be looking for organ-specific symptoms that may be markers of TB at other sites besides generally pulmonary, which is what we're most commonly treating. Treatment may be gradual, but we don't worry because sometimes it takes a little bit of time. But if people are not improving by about 2 months, and most patients will get better much before that, then you start to wonder, why is this patient not necessarily doing well, and are they failing their treatment? And then the whole time we're looking to see if the treatment is working, we're also going to be assessing for adverse effects of our medications. All right, so let's talk about microbiologic response, because that's something we pay a lot of attention to. For patients who start off with positive smears and cultures, we monitor their sputums monthly until we get 2 consecutive specimens that are negative. In practical terms, sometimes some patients, a marker of them getting better is that they stop coughing and don't have any sputum to bring up. So sometimes, we can't get follow-up sputum to see what's going on, but usually that's a good thing because they're better. And we certainly don't do things like bronchoscopies just to get additional sputums to see if they're better. But we do try and get smears and cultures, and we'll try and induce them in our clinics to see if we can get samples to show that their sputums have turned negative. The 2-month sputum culture is vital because that's one of the markers that we use to determine how long we treat people for. If people are not sterilizing their cultures by 2 months, then that sometimes is an indication that they will need a longer course of treatment therapy. Obviously, the other things that we want to do is respond, as we want to know what their isolates are susceptible to. Up until the recent past, that would be isoniazid, rifampin, ethambutol, and pyrazinamide. I don't know if it's been brought up in your sessions, but at the moment, there is a national shortage of some of the reagents needed to test for pyrazinamide susceptibility. So at least for a while, that is something that we're not necessarily going to reliably have information on. So if somebody is still culture positive at 3 months, that would be an indication to repeat your susceptibilities to make sure that they are still susceptible to the drugs you're giving them. So what you see on the lower part of this slide is this is what we would expect to see in a typical patient. Their initial sputum smear is positive and it's culture positive. Their isolate is pan-susceptible. They've been started on medications. And here we are about 3 weeks into treatment. Their smear is now negative, although they are still able to grow MTB. But then a couple of weeks down the road, before we hit that 2-month mark, they are now smear negative and culture negative. So that's kind of the expected response, but not necessarily the only response that we see. So what about this pattern here? So we have somebody who starts using the same time interval, 3+ smear positive and culture positive, pan-susceptible. And you can see that they are now getting into 3 months of treatment. At 2 months, they still have a positive smear and culture. At 3 months, it looks like their smears are less positive and we don't have cultures. What does this mean? Is this somebody that we should now be worried about? So let's take that, and this actually is data from a recent case at Cooper, and we'll talk about him for a little bit. So he's a 69-year-old, or at least was 69 at the time, with 9 months of 50 pounds of weight loss, fever, sweats, and worsening of a chronic cough. He's US born, does have a history of alcohol use disorder. He shows up to the hospital. His initial sputum specimens are 4+ AFB positive. He started on RIPE. He has a gene expert that was sent from his sputum. At that time, we couldn't do them in our hospital on site, so it had to be sent out to a reference lab, but it did come back showing that he had MTB, not a surprise. and had no resistance to rifampin. And that's obviously a very important piece of data for us because that's often the only piece of susceptibility data that you will have until that patient's cultures grow and you have additional susceptibility data. All right, so we start him on treatment. He's still in our hospital. We're 2 months into his treatment course. He's coughing a little less. His fevers have gone away. He's not gaining any weight yet. He's still at the same weight he was when he came into the hospital. He's been on RIPE now for about 8 weeks or 40 doses. He's still coughing up specimens that are all still AFB smear positive. His samples from the beginning on from the first month of treatment are growing MTB. And we don't have any later susceptibilities than the initial ones. So now we are 3 months into his treatment. Should we worry about his persistent positive sputum smears? He's been on RIPE now and he's had 8 weeks and we know it's pan-susceptible. Can we just de-escalate his antibiotics to isoniazid and rifampin? So what should we do? So this is the time where we get a lot of questions about, well, our patient's not getting better. He still has positive smears. He's clinically feeling a little better. He is certainly not getting worse. So think about that as we talk a little bit about what we did. He had a follow-up X-ray done, which is again one of the tools that we can use to see how we're doing. And you can see the comparison of his initial X-ray on the left there and his new X-ray on the right. And it does look like his upper part of his lung on the right there looks a little bit less dense. Looks like it's maybe getting better a little bit. All right, so let's fast forward another month. So at 3 months, we kind of didn't do anything. Now here we are at 4 months, and now we are once again still smear positive. Our cultures are positive up to 2 months, but obviously not yet back from the 3rd month. Are we worried now, 3 months into treatment, still with persistent smear positive samples? Well, some of us were worried, maybe. Now we are up to 4 months. And he's still smear positive. We now know he's culture positive at 3 months. Should we be worried now? Okay, so let's see what you all think about this. He's persistent positive sputum AFB smears, and we're now at 4 months of treatment. Which of these most likely explains why his AFB smears are not clearing? You have a number of choices there. Let's see what everybody thinks. I guess we can open the polls.
Yep, I've just opened the polls.
Okay.
Okay,
So
I'm
we'll give
gonna
you
end it.
Okay. Okay, so we have a number of different reasons that are there. Okay, so let's talk our way through these. So we'll close the polls here, but you can see that about a third of you think he just has really bad TB disease and he needs more time. Some of you are worried about drug resistance. Some of you, not as many, are worried about absorption. And obviously the question always comes up, well, they're smear positive. Are those live or dead organisms? And I don't see the answer there. Nobody likes the answer that maybe he has a non-tuberculous mycobacteria, but this does happen occasionally as well. So let's close this and talk through some of these answers. So here are my thoughts about this. Yeah, I think that extensive cavitary disease, we've seen people who remain sputum smear positive, although getting better for up to 6 months or sometimes even longer. And if you have really bad tuberculosis, that can be a slow process. We obviously always worry about drug resistance. The things that we can do to help ensure that that's not an issue is we really want to make sure they're getting directly observed therapy and on an effective regimen. This patient was in the hospital, so we make the assumption that they're getting directly observed therapy, but not all hospitals are quite as good at implementing directly observed therapy as we are in our tuberculosis clinics. But we know that we do want to recheck those susceptibilities at 3 months if the cultures are still positive. One of the things that I'll talk about a little bit more in a minute is checking drug levels. And anybody who seems to have a slow clinical response is an indication to think about getting drug levels, because we know that there are certain patient populations, including really sick patients, who don't necessarily absorb their drugs well. We obviously don't know if those smears that are still positive are live or dead. And you have to wait to see if those cultures grow. And unfortunately, we have no other markers, at least at this time, that tell us if what we're seeing on a smear is a viable or non-viable organism. And we have certainly seen patients who have also non-tuberculous mycobacteria, so their TB disappears after a couple of months, but they're still smear positive because they also have MAC or another non-tuberculous mycobacteria in their sample. All right, so here's what we actually found on our patient. His sputum AFB cultures that were smear positive at 4 months are now culture negative, and he's continuing to do better. We did check drug levels, and drug levels to first-line drugs. Probably the most important two that we check are isoniazid and rifampin. And it is very, very common to find that levels of the drugs, which are done 2 hours post their oral doses, are low, and they may require some dosage adjustment. So we opted, because of his slow clinical response, to treat him for a total of 9 months, a prolonged continuation phase due to his slow response and persistent positive cultures at 2 months. So let's talk about extending treatment courses. So why do we extend treatment courses? What is our rationale for doing that? Obviously, this is the final data on that patient. And the rationale for extended treatment courses is that we are trying to really minimize the risk of relapse of disease. We make the assumption that patients receiving a standard course of therapy should be cured of their tuberculosis without any evidence of relapse in the first 2 years after stopping medicine, probably about 98% of the time. If you give shorter courses for more severe disease, that risk of relapse is higher. That doesn't mean that many of those patients might not be cured, but that risk of relapse starts to go up from 1 to 2% to 5% to 10% on shorter courses. And that's the reason why we really like to extend those courses and why we have those 9-month guidelines, because we really don't want to ever have to treat these people again. So let's talk about drug levels for a minute. Drug levels on standard medication doses may be low in many patients, and the populations that we know just based on experience that are likely to have subtherapeutic levels. We know that that's very common in diabetic patients. It's very common in HIV-infected patients, especially those with advanced HIV disease. And it is also common in malnourished and other very sick patients. Now, do subtherapeutic levels, are they associated with treatment failure? I don't think we've been able to clearly show that, but they are associated with slower sputum sterilization and protracted treatment courses. So we considered doing drug levels in all patients with a slower clinical response. And depending on what state you're in, the criteria for doing drug levels vary. For example, I believe in Virginia, drug levels are done on all diabetic patients, and we end up doing them on most of our diabetic patients here, as well as our HIV co-infected individuals, and just really sick patients who we are worried about absorption. If you get low drug levels, then what you want to do is adjust those medication doses. And there is some guidance for how you make those adjustments. And we know, I mean, although there's probably a little more risk to increasing isoniazid dosing, if the levels are low, then increasing the dosing is generally well tolerated. And rifampin, we know there have been numerous studies where people have actually used higher than the standard 600 milligram daily doses that we use to treat most patients. And those doses have been shown to not increase the toxicity from rifampin when they're given higher doses. So there's a lot of safety if you have to increase the rifampin doses. Okay, so let's move on here. So X-rays, do we need an a follow-up X-ray at 2 months? One of the recommendations has been that a chest radiograph at 2 months can be helpful, but it's not essential to the management of your patient, especially if they're doing well. We are much more likely to make sure we have an end of treatment chest X-ray, because that's really our new baseline for comparison for what happens to this patient in the future. We know that many of the folks that we see may move around a lot. They may be seen in other jurisdictions after they leave us. They may have only limited access to healthcare and then may show up 2 years later someplace else with a history of tuberculosis and an abnormal X-ray. So knowing what their end of treatment chest X-ray is going to be very helpful if that patient ever reemerges in the future. Sometimes you will find surprises when you look at an X-ray, and we'll look at that in a second. But this is just an example of somebody who had pretty extensive tuberculosis to start with. That's the figure on the right, on the left. And then you can see as they are treated, they're left with their X-ray does not go to normal. They're left with a lot of residual scarring and volume loss on the right hand X-ray there, but that doesn't mean that they still have active disease. But that scarring and volume loss is going to persist forever. The one group that we always get a 2-month chest X-ray on are those patients who we're treating who are culture negative, but we've clinically diagnosed with tuberculosis. There, it is very helpful to see that their X-ray actually looks better after 2 months, because if you're treating them empirically, you want as much evidence as possible that your treatment is making a difference. All right, so other reasons that we might get a repeat chest X-ray is that patients can start to have worsening pulmonary symptoms and bad things can happen in their chest. They can develop pleural effusions, or if they had them to begin with, they can get bigger and they can get more short of breath. Every once in a while, bad tuberculosis with a lot of scarring, you'll get a pneumothorax. You can get compression of lung tissues, especially if you have a lot of lymph nodes in the chest. Or sometimes you'll develop pericardial disease as part of their pulmonary tuberculosis picture. And that will show up on a chest x-ray by an enlarging cardiac silhouette. This is a patient of ours in clinic not that long ago who had extensive pulmonary tuberculosis. You can see in his initial x-ray there, this was done in the hospital when he was first admitted, lots and lots of bilateral disease. He was started on treatment, was doing better. He showed up at clinic for a routine follow-up. And what you may or may not be able to see there is if you look around, this was a routine x-ray done in clinic, maybe a little bit more short of breath. You can see that rim there that the arrow is pointing to where there's black, and then you can see the edge of the lung. So he developed a pneumothorax. Luckily, he had so much scarring of his lung that the entire lung didn't collapse, because some of it was adherent, some of that pleural was adherent. And here is his CAT scan when we sent him to the hospital and got a CAT scan. And you can see that pneumothorax that was really only with mild symptoms, but we were able to pick that up on his x-ray in clinic. All right, this is a flow sheet for monitoring, for how we typically monitor people. We generally get sputum smears and cultures and susceptibility testing. Whether you do that beyond the second month is really whether or not they're producing any more symptoms. Like I said, you can get an x-ray at the second month. We obviously always look at symptoms and weight. If they're on ethambutol, we are monitoring their vision. But if that ethambutol drops out of their regimen, that no longer becomes important. And then the laboratory monitoring is essential in the beginning, but then becomes less important and more symptom directed. So this is just a side comment about how often we monitor laboratories in patients on TB treatment. Initially, we typically monitor our patients at least monthly. We may become, that frequency may decrease once they're doing well and not having any issues, especially when they're no longer on both isoniazid and PZA, which is much more likely to cause some liver toxicity. But this also is patient dependent. Monitoring is a little more important in patients who either are not able to tell you about symptoms or side effects or reliably report things, where it's often one of your few clues that you have that there may be something going on, and are probably less important in younger and healthier patients who are able to communicate whether or not they have symptoms. All right, so we talked about extending the duration of therapy beyond 6 months. And from a practical perspective, these are sort of the list of things that would make us want to treat patients for more than 6 months. Some of those would be that if they did not get rifampin and pyrazinamide in the initial 2 months of therapy, and we do have a fair number of patients who don't tolerate pyrazinamide or may have, and therefore you have to stop it early, and that would be an indication to continue treatment up to 9 months. If they have resistance, obviously, they're going to need a longer treatment course, although we actually have some very effective multi-drug resistant treatment courses that are only 6 months now. If we already talked about positive cultures at 2 months, if they have cavitary disease or if they're HIV positive, even without cavitary disease. And then there are certain extrapulmonary syndromes like central nervous system disease and spinal disease, where we generally will extend the duration of treatment. For brain disease, sometimes up to a year. For spinal disease, for at least 9 months. And then there are just some patients who are really sick that in our clinical judgment need a more prolonged course of treatment. Now, what about the opposite? Do we ever treat for less than 6 months? Well, there are a couple of scenarios where we treat for less than 6 months. One is someone with culture negative pulmonary disease. There are some examples of when we can treat for less than 6 months with drug susceptible pulmonary disease. And we in fact do have the new 4-month rifapentine moxifloxacin based regimen for treatment of drug susceptible TB. This is not an easy regimen to implement in the clinics. And often patients show up in our clinics after they've been in the hospital and been on an alternate regimen for over a month, and it seems to make less sense to try and switch them. But it is a treatment regimen that is now available and is the shortest effective treatment regimen that we can implement in a significant number of patients. All right, so we're going to kind of shift focus for the last part of this talk, and we're going to focus mostly on medication issues. So let's start with another case. This is a 63-year-old Vietnamese-born woman who has smear-positive pulmonary tuberculosis. She's positive by GeneXpert and does not have rifampin resistance. And she is started on 4-drug therapy with RIPE as well as vitamin B6 and is receiving her treatment by directly observed therapy through our clinic. At 2 weeks into her course, she complains to the nurse that the medications are making me sick and she wants to stop them. What do you do now? So let's talk a little bit about monitoring for adverse drug reactions. Collaboration between patients, prescribers, and the TB program is important as part of this process. Patient education is important. We have to educate our patients from the beginning about potential serious adverse drug reactions from their regimen. The biggest challenge that I find with this, and this is a little bit more of an art than a science, is learning how to educate patients without making them unnecessarily anxious. Because you want them to know about what could happen, so they'll tell you about it, but you also don't want to make them worry that everything that they have is a symptom of something really bad. And that's just something to be aware of, that there is a little bit of an art to trying to do this. You also have to make sure they are aware that they need to report symptoms, but you should also never presume that they're going to tell you about everything that's happening. Some patients just never report anything. There are language and cultural barriers that get in the way of whether or not patients report symptoms. There are neuropsychiatric issues. Sometimes, especially elderly patients may be having symptoms, but they're not as aware or attuned or able to explain what's going on. So there's really a lot of reasons why, just because a patient doesn't tell you something is happening, when you then ask them about it, they may tell you about it if you ask them directly. But if you just ask, are you having any problems, they may not tell you about something that may be a very important side effect. Our staff need to be aware of the potential adverse drug reactions from their medications. And we take every opportunity that we interact with our clients to make sure that we are asking them about any medication side effects. And it's important to make sure that these are documented and communicated to the rest of the staff. If you have 3 or 4 different people who may be doing directly observed therapy on a patient, and one of them learns about something that's at least something that needs further monitoring on, or that other people should be asking, that needs to be documented and communicated to whoever else may be doing the directly observed therapy to try and find these things out before they become big problems. So the other things that are important in medication monitoring is making sure that you are aware of any other new medications that our patients are getting. And that includes both prescription and non-prescription medications like supplements. And if they have multiple physician providers, as many of our clients do, because they may be seen in our TB clinics, but then they have a separate medical clinic. Some of our co-infected patients have separate HIV prescribers. It's really important to make sure that we're on top of changes in their medications to try and prevent unnecessary adverse drug interactions. And one thing that's important, if you are in a freestanding TB program and you are not integrated with the electronic medical records of the hospitals around you, those hospitals may not have the patient's TB medications on their electronic health record. So when that patient comes into the hospital, if the patient can't tell them that they're taking isoniazid and rifampin, and it's not on the electronic health record, then nobody may know that when they're first admitted to the hospital. When we talk about medication interactions, the big culprits are rifamycins, mostly rifampin, and that is a reason why you'll see a number of patients who are getting rifabutin, because although it doesn't eliminate the risk of drug interactions, it can be used safely with some medications that rifampin may not be. And you also want to make sure that as you are monitoring patients, keep an eye on their weight and keep an eye on their renal function, because both of those may be important for making medication adjustments. So when we talk about the common types of adverse drug reactions, these are the primary ones that we see. Gastrointestinal toxicity is probably the most common, but also hepatotoxicity, hypersensitivity reactions, and other dermatologic reactions. And then I've listed some of the less common ones on this slide as well. This just is a table. This includes the first-line anti-tuberculous medications, as well as the fluoroquinolones, because that's often a replacement drug, and we have probably as many patients or more patients on fluoroquinolones than we have probably on pyrazinamide or ethambutol at any given time. And this just shows you that there are some side effects that can be seen with any medication, like gastrointestinal side effects, whereas some of these side effects are drug specific. So part of your monitoring plan is really focused on what are the drugs my patient is taking and what are the potential things that they could have. You can see that gastrointestinal side effects can be caused by anything. And here would be the side effects that if somebody's on isoniazid, the more common and less common ones that you might think about. So let's just take a couple of minutes to go through some of the common side effects and part of our monitoring plan for the most common drugs. So let's start with isoniazid. What are the common and less common adverse drug reactions, and how should we be monitoring them? Oops. So I believe there is a poll question for this, or at least a fill in the blank question.
Yeah,
Okay,
I
here we
just
go.
shared it I just shared with everybody.
All right, so why don't you all take just a few seconds to talk, fill in your thoughts on the common adverse drug reactions, the less common ones, and how you're going to monitor somebody on isoniazid.
I see no responses. Are people having issues with accessing?
I'm just typing still.
Oh, perfect. Okay, thank you. Thanks for the heads up.
All right, so I submitted one, so you should have at least one.
Yeah, I see a few more responses. Thank you so much. Should I end the poll, Dr. Freeman? I think we
Yeah,
have a couple
sure.
responses. Okay.
So let's see what we have in here. I see my answers. I'm not sure I see other people's answers, but so these are, so I think that from what I'm seeing, the most common things that people worry about with isoniazid would be hepatitis, as well as some people have peripheral neuropathy in here, either as common or less common. And for monitoring, we obviously are going to ask people about signs and symptoms of hepatitis. We're going to examine them and hope that they don't look yellow when we look at them. We can check liver enzymes to monitor for hepatitis. And we obviously will be asking them about peripheral neuropathy symptoms, numbness and tingling, especially in the feet. Sometimes, especially in some of our patients like diabetic patients, they may have baseline neuropathy, and those are the ones who are at higher risk for developing worsening of their symptoms. So let's move on to the next drug.
There's a comment in the chat to Dr. Freeman. Morella Valles has said that counseling to avoid alcohol ingestion, avoidance of
Yeah,
acetaminophen as well.
absolutely. We want to make sure that they're not taking additional hepatic toxins. Alcohol is a really challenging one because we do see a significant number of folks who have underlying alcohol usage disorders, and sometimes that is, they are drinking even if we don't know that they're drinking, or they won't admit that to us. Oh, and the other thing I should mention is that in appropriate populations, we may also screen at baseline for hepatitis B and hepatitis C, because if they do have chronic hepatitis B or C, then they may be at higher risk for liver toxicity on hepatotoxic medications and may need more frequent laboratory monitoring. Okay, so let's talk about rifampin. Take a minute to put in your thoughts about rifampin. Here I've also, here you'll notice that I have put in the distinction between side effects and adverse drug reactions. Side effects are things that we expect from when we administer the drug. They generally don't require change in medication, but it is important for us to warn the patients that those are things that might commonly occur, as opposed to adverse drug reactions, which are more serious. So why don't you all fill this in, and then we'll talk about this in a second.
Okay, I'm gonna end the poll.
All right. So let's see what some of the things that we might think about. So side effects with rifampin, the one that always comes up is red or orange colored urine. It's not really an adverse effect. It's an expected side effect. But it's important to tell the patients about it so that they don't freak out when it happens. However, we do have some adverse drug reactions from rifampin, and that list is a little bit broader. That includes things like nausea and gastrointestinal symptoms, less commonly hepatitis, in fact, much less commonly than isoniazid or pyrazinamide, but does happen. Rashes are relatively common with rifampin. Less commonly, you might see severe thrombocytopenia. So some of our monitoring plan includes counseling about side effects, as well as monitoring for any of those reactions. Occasionally, lab monitoring is part of that as well. See if there's anything. Yes, and somebody mentioned, which is important, and he's going to talk to about that a little bit later, is counseling about contraception and pregnancy. I guess you could consider pregnancy to be an unwanted side effect of rifampin usage, because if you're on oral contraceptives or even some of the injectable contraceptives, rifampin will increase metabolism of those drugs and make your contraception less effective. So that is an important component in women of childbearing age about rifampin usage. All right, so let's move on and talk briefly about ethambutol. And again, we have opportunity to fill in your thoughts about this. Common and less common in our monitoring plan.
Okay, just launched the poll.
Okay, so I guess we can take a look and see what people think. So, okay, so the main thing that we are worried about with ethambutol is ototoxicity, which is specifically optic neuritis. And our monitoring for that generally consists of vision and red-green color blindness monitoring, because those are some of the earliest findings. I can tell you that when patients complain of eye symptoms, that can be challenging, because we obviously never want to miss ethambutol optic neuritis, which can potentially be irreversible if you let it go on for too long. But at the same time, patients get many eye symptoms for many different reasons that have nothing to do with their medication. And unfortunately, we're not ophthalmologists. Every once in a while, we even see people who actually have tuberculosis, TB uveitis, which can present with some eye changes. Typically, optic neuritis is bilateral. It's generally not painful, so there are some clues that you can try and get when someone's complaining of symptoms. Less common reactions with ethambutol. Rarely it can cause joint symptoms, but it actually is one of the more common causes of drug rash. The one other thing to keep in mind with ethambutol is dosing is important. It's one of the drugs that needs the levels, the dosing adjusted by renal function, and especially in elderly patients or patients with comorbidities and poor renal function. This would be a medication where you want to make sure you're monitoring their creatinine to adjust the dose if necessary. All right, so let us go on and move on to the last of our, actually, no, we have two more drugs to talk about. Let's talk about PZA next. And we can talk about monitoring for this. I guess we can throw up the poll.
And the poll has been launched.
Okay, thank you. Okay, we'll give people another 10, 15 seconds and then we'll close it up.
Sounds good. Okay, I'm going to close the poll.
Okay, so what can I tell you about PZA? I can tell you this is our least favorite drug in our clinic because we seem to have more problems with PZA than any of our other medications. So the common side effects, which many of you have brought up, joint aches, and much less commonly, but potentially more serious, would be actually precipitating gout. And then the other common side effects, it probably is the single biggest culprit for GI toxicity in our patients and hepatitis, and can occasionally cause rashes and a variety of other symptoms. Seems to be the drug that our patients least like being on. Symptom monitoring is important. In patients with history of gout, it's not clear how helpful. We might get a baseline uric acid, which is not a contraindication to use of the medication, but may help identify gout when it occurs. And these patients on PZA are also generally monitored, have their liver enzymes monitored fairly regularly. Okay, let's close that out and let's move on to our last of the sort of frontline drugs, and these are fluoroquinolones. So common adverse reactions, less common, and how we monitor.
I just launched the poll.
Okay, thank you. Okay, we'll give you another couple of seconds and then we'll end that. Okay. So some of the serious adverse effects, one of the ones that we worry about a lot is tendon rupture, particularly in older patients and patients who are also on corticosteroids, which seems to increase that risk significantly. There's really nothing preventive you can do about it except discuss it with patients. Some less common toxicities, neuropathy, gastrointestinal toxicity, headaches, rash, although rash probably less common than some of our other drugs, and hepatitis also less common than some of our other drugs. So a lot of this involves counseling, but be prepared to expect that some patients will have issues with fluoroquinolones. The other thing to keep in mind is that unless there's severe adverse drug reactions, a lot of these minor symptoms, some patients will have it with levofloxacin and not moxifloxacin, or the other way around. So if quinolones are important drugs in the treatment of your patient, you can always try and switch to the alternate fluoroquinolone. Okay. So let's move on and talk about state-of-the-art management of common adverse drug reactions. So this is really the practical state of the art. How do we handle these? Well, we basically stop medicines and see what happens, especially if we don't know which of the drugs is causing it. And unfortunately, that's pretty much all we can do is stop and restart medicines. That's pretty much the toolkit. So let's go back to our client that we were talking about, our 63-year-old Vietnamese woman who is complaining that her medicines are making her sick. So what would you do now? And we have a poll question here. Everyone can take a look at this and put in their thoughts about what they would do next. And we'll give you all just a couple more seconds to vote, and then we'll look at what you all thought.
Okay, I'll be closing the poll.
Okay, so we're going to check LFTs, which I think is a really good idea. Although she doesn't have to have hepatitis, and gastrointestinal toxicity can overlap with hepatitis. You can't say it's not hepatitis unless you check LFTs. And many of you also wanted to get more history and make sure you were fully understanding what she means by the medications making her sick. She's Vietnamese speaking only, and obviously understanding exactly what she means helps us to formulate our management plan. Some of the other things that are on that list are things we might think about once we've sort of gotten past those first two. So I agree with everyone that those are the first two things that we would do. So let's talk a little more about, so this is my overall thought process when I'm thinking about potential adverse drug reaction type symptoms. When I hear about a patient who's having a problem, my first question in my head is, could this be an adverse drug reaction? And then practically, is this someone we need to see right away in clinic? Is this someone we need to get lab work on? how do I talk to the patient about what side effect, what her symptoms may be, his or her symptoms. Then if I think it could be an adverse drug reaction, could this be a serious adverse drug reaction? And then to do that, if I think it's serious, do I need to stop some medications, one or all of them? Do I need to start new medications? And if I need to stop medications, when can I restart them? So that's just sort of my mental overview when thinking through potential adverse drug reaction symptoms. So we're preemptively monitoring for these. And when someone has new symptoms, we have to think about, is this likely due to a toxicity from their medications? And do they have specific risk factors? We always want to rule out common or less common, but potentially alarming causes of the current symptoms. And we also want to be able to do things like distinguish, is this just medication-induced nausea and vomiting, or do they really have hepatitis here? And then we also want to know how severe it is. Some adverse drug reactions are self-limited and can be treated with supportive care. Some require alternate therapy. Some require hospitalization if they're very severe. And one of the challenges with adverse drug reactions is that our clients don't like having them. And sometimes it may make them more reluctant to take medications going forward after they've had one bad experience. So continued monitoring for adherence is very important. So this is what happened with our client. She says that when she takes her medicine, she feels sick to her stomach, like she might throw up, and she can't eat. She's not vomited. She doesn't have abdominal pain or dark urine. She's lost about 2 pounds. She has blood work done. She has a very mild elevation in her ALT, which is less than twice the upper limit of normal. A bilirubin is normal. So what can we do now, and what interventions can we try? So GI toxicity can present in a variety of different ways: nausea, vomiting, diarrhea, bloating, abdominal pain. It overlaps, as we said, with hepatitis. Any drug can cause GI toxicity, even drugs we wouldn't think that would do it, like ethambutol. It usually occurs early, within the first few weeks of treatment. This is, in our experience, what that hierarchy is. PZA being the biggest culprit. Fluoroquinolones also cause GI toxicity. Many of the other second-line drugs that we use for resistant tuberculosis can cause GI toxicity. But as we already talked about, you can sometimes switch drugs in a single class, and they may not have the same problem with the alternate drug. We can change the managing after we've determined there's no hepatitis. We can modify timing. We can modify whether or not we give the medications with food or not. We generally don't use intermittent therapy much anymore. We can try using antacids. We can try using medications that are for anxiousness if they seem to be really anxious prior to taking their medicines. And we can use antiemetics to try and control the symptoms. And generally, these are best given before their medications rather than after, so that they won't develop that nausea or potential vomiting with the medications. So let's go back and think through, well, let's say our patient did have elevated liver enzymes. So I'm giving you 2 examples here. The first is mild elevated transaminases, and the second is very high transaminases and a high bilirubin. And if you have hepatic toxicity, or what we refer to as drug-induced liver injury, we already talked about things like supplements, alcohol, and other viral hepatitis, and every once in a while in patients with severe TB, the liver abnormalities are actually a manifestation of their TB disease. You can get asymptomatic increases on isoniazid in about 20% of patients that don't require stopping the medication. If patients are having symptoms, then when you get to 3 times the upper limit of normal, that's when you would stop medications. If they're asymptomatic, that threshold for stopping medications is higher. Fulminant hepatitis from isoniazid is actually pretty rare, but does happen. But it is often worse because people miss the symptoms. And one of the things about isoniazid hepatitis is it's one of those things that is idiosyncratic and can actually occur anytime during the treatment course. So even somebody who's on their 5th month of a 6-month course could potentially develop hepatitis at that point. These are some of the risk factors for hepatotoxicity, and you can see them here. And these are some of the thresholds. The challenge is if they have really bad tuberculosis, do they still need to continue? You need to find drugs that they can take that won't contribute to their hepatotoxicity. So there are liver sparing regimens that you'll see on the slide here. All right, so we already talked briefly about pregnancy related to rifampin and contraception. Pregnancy is not a contraindication to treating TB disease. However, it may be a reason to delay treatment for TB infection. And women of childbearing age need to be counseled about becoming pregnant on TB treatment, even though our medications are generally considered safe in pregnancy, except for pyrazinamide. Pyrazinamide in the US is considered to be relatively contraindicated in pregnancy, although the World Health Organization thinks that it is a safe drug to be given to people with TB disease in pregnancy. And we already talked about rifampin. All right. The last slide here we're going to talk about is rechallenge. So how do we rechallenge people? Well, when their liver enzymes fall to less than 2 times the upper limit of normal, what we generally do is sequentially restart the drugs, starting with the ones least likely to cause hepatitis, and then adding in the more hepatotoxic ones. And sometimes if they're doing fine on rifampin, ethambutol, and isoniazid, and they had really bad hepatitis, we may not restart pyrazinamide because we can treat them even if their treatment course might be a little bit longer. All right, so these are just a few take-home points from what we've talked about. And then I think we'll have maybe a little bit of time for some questions at the end. So monitoring includes monitoring for TB disease response and for adverse effects of medication. You can monitor clinically, microbiologically, by X-ray. If you're monitoring extrapulmonary disease, that can be a lot more challenging than pulmonary disease because some of those symptoms are harder to monitor and some of that disease is only you can only tell it's there by imaging like CAT scan. So it's hard to know if somebody's symptoms are not getting worse, whether or not their brain lesions are necessarily getting better. We always worry about drug resistance, but there's many reasons why patients aren't getting better as fast as we'd like, and always think about monitoring of drug levels. Patients who respond more slowly may need more prolonged treatment. And we talked a lot about adverse reactions, actually pretty common. In some of the series, at least 10% of patients will have a serious adverse drug reaction to at least one of the frontline TB medications during their course of treatment. And monitoring is an active and continuing process. All right, so I think that's the end of my slides. So any questions that we haven't addressed?
Yeah, if anybody has a question, you can unmute yourself or you can put it in the chat.
Okay, well, doesn't
Um,
look like I'm seeing, oh,
oh,
here's one.
Yep.
Um, I think that you can start PCA in a patient like this and re-challenge to see if you can then complete a shorter treatment course. But this is really during, I sort of individualize this patient by patient. It depends on how bad their hepatitis was to begin with. And also depends on whether they had other bad symptoms from the pyrazinamide in addition to the hepatitis. And many patients will tell you that's a bad medicine. I don't want to ever take it again. In which case, I probably wouldn't try to re-challenge. But if they had milder hepatitis and they really want to be able to be treated with a shorter course of therapy, I think that you can restart PCA, but just be aware that they could have problems with it. All right, anything else before we
Okay.
wrap up?
Yeah, I think that's it. I just wanted to thank everyone, and I did include the evaluation link. If everybody can just click that, that's on our chat. Dr. Freemal, thank you so much for your time today and for presenting. We really appreciate your work, and I want to thank everyone. Have a wonderful weekend and have a great day. Thank you, Dr. Freemal. Bye-bye.
Bye-bye.